go on to the second case.
Let's go. This case is a 30-year-old woman who is a non-smoker again. She has progressive dyspnea. She has antibodies against pigeon, parakeet. Parakeet, is that the word?
Parakeet, yeah.
Yeah.
But not parrot.
Not parrot.
Okay.
Correct.
Very important.
Very important.
But no
to get your
exposition
birds right.
to very important. No exposition to neither of these animals. And the CT shows fibrosing pneumopathy. Fibrosing pneumopathy. Who wants to talk about this biopsy?
You can take
Any
this one.
volunteers, guys?
I can take this one.
Go ahead, Matt.
So we place the different pieces of the cryobiopsy in a 6-hole cassette. We put in this space we put kidney or liver, and then we place here piece number 1. We place here piece number 2. We place here piece number 3, number 4, and number 5. And that's how it's useless, but you could say if there is an infarct or a meningoarterial nodule in the specific segment. It's not, the cryobiopsies are gotten from the same law, but maybe from different segments.
Sounds great. Well,
Mark,
these look like great pieces of lung parenchyma, pretty substantial, and you can see that there's some focal abnormalities to them, where even at this low power, you can pick out that there's granulomas there. They look like they're non-necrotizing. With the history you gave, the first thing that comes to mind with it is HP, but these granulomas to me don't really look like the granulomas I would expect in HP. They actually look more sarcoidal to me. The reason I say that is there's a kind of paucity of inflammatory cells associated with them. They're really tight and well formed. They're very easy to see at low power, and so HP is in the differential hypersensitivity pneumonitis, but I would be more worried about sarcoidosis. The distribution is lymphangitic in a way. It's accentuated around these airways. I don't know if we have any pleura as well with it, but I think I'd want to correlate with the imaging, look and see if she has any hilar adenopathy history as well. But I worry that the history you gave of the antigen reactivity to those parakeets is actually a red herring in a way, or a red parakeet in a way, I guess, and that you're trying to trick us, and that's. But I would.
Many people has antigens against.
Yeah, exactly.
This. And it doesn't make that you have an illness.
So I think I would bottom line this as non-necrotizing granuloma, and then I would make a comment. I would obviously do stains for fungal and acid fast organisms, even though it doesn't really have the appearance of what you would see in an infectious granuloma. But make a comment that the differential includes sarcoid. Oh, it's got an asteroid body. It must be sarcoid, right, Sanjay?
Would you comment on this fibrosis that it's? Do you think this is fibrosis, or would you say necrotizing granulomas or fibrosing, or?
I think I might comment a little bit on it, but I don't know. To me, I think this could be sarcoid. Like, I think I wouldn't. I don't think that there's a distinct fibrotic lung disease.
Oh, a distinct.
Yeah, no, but you're right. I think I would comment on that.
That it's advanced, advanced, or that it's fibro, because they said fibrosing, but sarcoidosis can do it.
Yeah. Do others agree with me? Or is it? Do you blame the parakeet?
Let's hear Raghav and Sharada, then I'll give my thing.
Yeah, I think pretty much I do the same thing as Matt. But again, infection is something I always think about. But in this case, I agree that the clock is more towards sarcoidosis with the appearance of the granulomas and hyalinized fibrosis around them, which again correlates with the CT findings too. But again, along with that, I will also check the CT to see the hilar mediastinal lymphadenopathy if it's present or absent. But it fits like lymphangitic kind of pattern distribution of the granulomas, and they're very hard granulomas. That means non-necrotizing. And then if there's an occupational history of something else, berylliosis, the granulomas don't have, they generally have some lymphocytic infiltrate around the edges of the granulomas. So I would just think it for myself. And if it's a resident, I will talk about berylliosis to the resident, but not to the clinician. Not to the clinician, not to confuse him or anything. But I would do the bug stains, even though I knew in the back of my mind the GMS and AFP, the Nielsen would be negative. But if I don't do it, then the clinician would ask me to do it. So I will do it even though it's going to be negative. So I think that's my thought process.
Sharada, what would you do? Any thoughts?
So yeah, I agree with the diagnosis. Even I will go for a sarcoid granulomas because the morphology is fitting into it. I couldn't find any eosinophilic granular necrosis because that will be the first one which I will think of, tuberculosis in India, because that is more common than sarcoid. So even if I don't find any eosinophilic granular necrosis, definitely I'll do the bug stains, I'll do the AFB, and because non-necrotizing granulomas also can occur in tuberculosis and mycobacterium.
So Sharada, can I ask you, because you see way more tuberculosis than anybody here does. Can I ask you, so in your setting, when you get a perfect non-necrotizing granulomas like this, right? No necrosis at all.
Yeah.
How often do you find a positive AFB in that kind of a case?
No. The positivity rate is like, in fact, in my experience, it is absolutely nil. I didn't find positive AFB when there is absolutely no necrosis at all. I didn't find AFB positivity.
Yeah, zero, right? In your experience,
zero. Yeah.
Which raises the question, like, why do we even do it?
AFB stain in these cases, in such cases, because the first thing that I have to rule out and also tell the clinician is that it is not tuberculosis.
Yes. No, Matt's question is a good one. Then why do we even do it? But I think Raghav kind of answered that. Is we know that it's not going to be positive, but the clinician might ask. Exactly. And it's just a pain to deal with them and explain to them how we know that it's going to be negative. It's easier to just do it and report it as negative.
Yeah. So for us, it is an everyday question: is it a sarcoid or is it a tuberculosis?
Yeah. Totally understand. Yeah, so I agree with all of you.
OP.
Same. Oh. Yeah. Oh, OP, look, maybe this is from the previous case, the one with, with the radiologic OP. Yeah, the other thing I'd mentioned here, Irene, is that, so that history is still correct, right? The parrot and parakeet and all that is correct? They had antibodies
yes,
to the...
yes.
Yeah,
I made up some data, but these are correct.
Yeah. So one thing that is for sarcoidosis here is that when you look at the lung away, like this kind of lung, it's completely normal. Yeah, which does not make sense for hypersensitivity pneumonitis. So even if they think it is hypersensitivity, I would say, no, look, pathologically, it's not. It makes no sense to not have a lymphocytosis in the interstitium away from it. And like everybody else mentioned, the granulomas are completely wrong for hypersensitivity. It looks like sarcoid to me too. Yeah, I completely agree with all of that.
Hypersensitivity, pneumonitis, and we lack the pneumonitis.
Right.
We need the pneumonitis. I tell that to the residents, that we need the inflammation away. Some people, and I have struggled, I admit I have struggled in the beginning of me signing out cases with, because we say many times the granulomas have not inflammations, and some have some, and some have less. But the thing is, no inflammation away from the granulomas. If it has a thicker or a thinner crown of lymphocytes, it's not that important. But the lack of pneumonitis away, it's very important.
Yes. I think that idea comes from Robbins or somewhere, that naked granuloma idea in sarcoid is that sarcoid only has to be granuloma and there should be no inflammation. That's not correct. I mean, you get so much inflammation next to the granuloma in sarcoidosis in some cases, lots of lymphocytes and all that, but it's the lung away from the granuloma that has to be normal and is almost always completely normal in sarcoidosis, the lung away from the granuloma.
Cool.
What do we need to label this sarcoidosis? That somebody what correlation or what would we need to? I mean, we all say non-necrotizing granulomas and the clinician puts the name sarcoidosis? That's the thing.
Yes, yes, that's what
Could
I would
this
do.
be
Non-necrotizing granulomas, see comment, and then explain the whole thing in the comment.
Could it, because this could be berylliosis, as Raghav said, if the history was different or that. Okay.
Raise your hand, whoever has seen a case of berylliosis that looks like this. Anybody?
No.
I don't think I have seen a case of berylliosis.
Exactly. Exactly. It's been 16 years. You know, I've been practicing now for almost 16, 17 years. I've only seen one good case of berylliosis with granulomas. The rest, you know, we do a lot of beryllium biopsies here. Almost all of them are normal or have non-specific, you know, a lymphocyte here and there. So I feel like for sarcoidosis, which all of us see, right? We all see sarcoidosis commonly every day, every week. We see probably thousands and thousands of cases of sarcoidosis. To bring up berylliosis is almost like, you know, it's like talking about a zebra.
Yeah.
Yeah, I've seen in the teaching files, that's it. I've not seen personally a real case. But I agree that sarcoidosis is much more common and infections are much more common. And it just that it always comes to my mind because that one case which I saw in the teaching file has stuck to my head like an arrow. So that's why I keep bringing up confusing my residents.
No, but it's, you know, that saying, right, Raghav, it says the exception proves the rule. This is an example of that.
Yes.
I would like to ask one query. So what's your experience with both sarcoid as well as tuberculosis? I mean, combined, the patient has both sarcoid as well as tuberculosis.
Yeah, Sharada, whenever I give a lecture for an Indian audience, they always ask that, you know, because you guys have to deal with that problem so much. And it's obvious, you know, because you have much more TB there. And I practiced there when I was a resident, you know, but I saw that problem of so much TB. And so it's an issue. But here, like where I practice now, in the US, there really isn't that issue. So to see TB alone, forget about TB and sarcoid, to see TB alone is so rare here, so that to see TB and sarcoid, I've just never seen that together. So I understand why it's a problem in your setting, but here it's just, doesn't.
Here we are seeing cases where the patient has both sarcoid as well as tuberculosis.
Yes. And I don't see why it cannot happen in an endemic area, you know, why just by chance you can't have both. For example, in my setting, I have seen a case or two of histoplasmosis along with sarcoidosis. So it can happen, you know, you can get a classic histoplasma granuloma with bugs in it, and then classic sarcoidosis in the lung away from it. And people don't believe it because they think, oh, no, that must be the part of the histo, but it's not, you know. So I think it's rare, but it can happen just by chance that you can get an infectious granuloma and sarcoidosis together, but it's pretty rare.
What about this sarcoid-like reaction?
To what, Irene? To tumor or to
Perfenidone?
To tumor or to other things when they appear with this suspicion of sarcoid-like reaction. Oh my God.
I don't really believe that, you know. So I'll tell you why I don't believe that, Irene. I do believe that tumors can have granulomas next to them. No question. That can happen. It happens in seminoma, in Hodgkin's, you know, we know that. Every pathologist knows that. And sometimes even solid tumors, you know, like carcinoid or something like that, there will be a few granulomas here, a giant cell there. But that's not sarcoid-like, you know. It doesn't have a lymphangitic distribution. It doesn't have a tight thing. It doesn't have the concentric fibrosis. So I do understand that granulomas sometimes happen next to tumors and they are not sarcoidosis. They are so-called sarcoid-like, but they're really not sarcoid-like. And if they are sarcoid-like, like if they are well-formed granulomas along the lymphangitic, I actually suspect those really are sarcoidosis. So if you have all the features of sarcoidosis, it probably is sarcoidosis along with a tumor. I don't think that the odd granuloma here and there really deserves the label sarcoid-like. But I'll open it up to the others. What do you guys think? Matt, Sharada?
Yeah, so I had a case, I signed out a case where the patient is a treated case of non-Hodgkin lymphoma, and the lymph nodes have enlarged after treatment, and the pulmonologist got it out of recurrence, and then they had done a biopsy where I could see the sarcoid-like granulomas. So I wasn't sure whether this is a sarcoid-like reaction to the malignancy or whether it is like, it's a real sarcoid. So I have just put my differentials in the comment and I have signed out the report.
Got it.
Yes.
Raghav, Matt, anybody?
Same with me. Same with me, that common things first, and just like how we should not think about berylliosis, I don't think about sarcoidal-like reaction, because for me, when I'm looking at granuloma, the most important thing is necrotizing, non-necrotizing. I will stick to the basic approach of the granuloma. I will not try to make some weird combinations which doesn't fit to my thought process. So I've never gone to sarcoidal-like reaction whenever I looked at a granuloma or something like that. So again, there are some articles, like one article I saw in the Chest Journal where it mentioned perfenidone can cause sarcoidal-like reaction. And there are some other drugs can also cause some sarcoidal reaction. And again, we don't know what was the appearance of those granulomas. Like Sanjay was mentioning, was it fitting the sarcoidosis picture, like the lymphangitic, all those kind of stuff, or even the appearance of the granulomas. So I don't know that part. So I generally try to avoid that kind of confusion or contradictory kind of histological descriptions in at least my report. That's what I think so far I've done, but I might be wrong on that.
Yeah, I agree. I just deal with it in my comment. I just say that, the morphology favors sarcoid, but it's a diagnosis of exclusion, and other, rare causes, must be excluded, right? Whether they're on some rare drug or something. To me, it's a clinical pathological correlation that sorts that out.
So in my case, there was no malignancy in the adjacent lymph node. It was like the entire lymph node was showing a sarcoid granulomas. There was no malignancy in that.
Cool.
So again, when do you say exactly sarcoid? Because of the distribution or the shape or everything? Because I say non-necrotizing granulomas, and maybe I comment if they suspect sarcoidosis that the morphology and distribution agrees with the suspicion of so. But I don't say sarcoid granuloma.
In the line?
The line.
Irene, like, let's say this case, okay, the case you just showed. In this case, let's say you had knowledge that the patient has bilateral hilar mediastinal adenopathy. There's clinical suspicion for sarcoidosis. Even in a cryobiopsy here, I would say non-necrotizing granuloma is consistent with sarcoidosis. I would put that in the line if I knew that. And then let's say you had a surgical biopsy, right? And you had the perfect thing, everything is perfect for sarcoid. So the morphology, the distribution, the hyalinized fibrosis, even in those cases, I say non-necrotizing granuloma is consistent with sarcoidosis. But if there is any doubt in my mind that it might be something else or that there's something discordant, that's when I back off and I just say non-necrotizing granuloma. So that's my approach. I do put sarcoidosis in the line sometimes if I feel that it's absolutely clear cut that it's sarcoidosis.
When granulomas are apparent, when they have fibrosis and are distributed along the lymphatics.
Yes, and if it's a small biopsy, if the clinical setting is, if they're suspecting sarcoidosis, that also helps me to say consistent with sarcoidosis in the line diagnosis.
So even I put that line when everything is correlating in my cryobiopsies as well, because even we get like a very good, big cryobiopsies where I could find in case of sarcoid, I could find the lymphangitic distribution, and when everything is correlating clinically as well as radiologically, even I go ahead and put that line non-necrotizing granulomatous consistent with sarcoid, and again correlate. That's what I put the line as.
That's great. So good news, she gets to keep her bird.
Yeah.
We just saved a
she
bird.
Didn't had even she didn't even have a bird, only the antigens.
Yes,
Oh,
can
she
I
gets to
bring
keep
up?
her feather pillows then.
Yes, Matt, I know it's totally in jest, but actually there is a serious component to this, which is, now that we know this is sarcoidosis, I mean, all of us are lung pathologists. We know this cannot be hypersensitivity, right? So we ignore the positive, whatever parakeet antigen or antibody or whatever it is. The problem is, if this patient had a fibrosing interstitial pneumonia, right? In that setting, you would not ignore it. I think that's where we go wrong in interstitial lung disease, is that we know that these antibodies are non-specific, and they don't necessarily mean that the process in the interstitium is related to the antibody. But when it comes to a fibrosing interstitial pneumonia, we don't have any confidence in our, so the moment it comes to interstitial fibrosis or chronic inflammation, everything becomes hypersensitivity if you have some kind of a clinical indication. So I think we are not skeptical enough in that setting as we are here. Appropriately, in this case, we are skeptical and we are saying, oh, no, you can have antibodies. Anybody can have antibodies to a parakeet. But that also applies to the fibrosing interstitial pneumonias.
Agree. Great point. Should we move on to the next case?
Antibody? Yes.